John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I've asked Dr. Jason Fleming, one of our CSAP 17 authors, to speak with me today. Jason, can you share with our audience a little bit about yourself, where you're located, what's your primary focus of your clinical practice, and if possible, give us a little idea what your usual day is?
Thanks, John. I'm happy to be here. My background is originally from Memphis, Tennessee, trained as a medical student at the University of Tennessee, Memphis, and then spent the next part of my career in Texas, was in Dallas at UT Southwestern, Parkland Hospital for general surgery training, and then MD Anderson for surgical oncology fellowship, and then worked in both of those institutions after graduating from fellowship, and most recently transferred from MD Anderson to Moffitt Cancer Center here in Tampa, Florida, where I serve as the chair of GI oncology. My days are spent, I like to joke that I'm 50% clinical, 50% admin, and 50% research.
That sounds about right, Jason. That sounds about right.
So I do all three of those things.
Okay. Well, I want to thank you for that introduction, and I've asked you to share some of your thoughts about various conditions a surgeon faces relative to topics from CSAP 17, and the topics we're going to be talking about today are in the elementary category. Some of the topics come from CSAP 17 questions, and others will be from questions that were written but were not selected for the final draft of CSAP 17. Some of those discussions are great, and I hate to lose all of them just because we have so many good questions in CSAP 17. So I'm hoping to pick your brain about many of these, especially those that a general surgeon may find themselves confronted with in their practice. So let's get started. The first thing is, how about pancreatic cystic lesions? We had a lot of questions on cystic lesions of the pancreas written by many of the CSAP 17 committees, and I'm going to make a supposition that that means they must be a common occurrence in everyone's practice. How about yours?
Absolutely, John. We see these every week. I'm focused on pancreas cancer and other pancreas problems, but I think all general surgeons are seeing more and more of these. And I think if you look at the demographics of pancreatic cysts, I think there's a reason why. Two things, I think, contribute. One is if you look at autopsy series that have looked for pancreatic cysts, if you, when they do autopsies for whatever reason, for individuals over 65, up to 25% of them have cystic lesions in the pancreas. So I think part that, coupled with the high frequency of CT scans of the abdomen performed for various reasons in our healthcare system, contribute to these findings. And then at that point, no one's sure if that represents pancreas cancer or high-risk lesion or nothing. So they send them to the surgeon.
Okay. And is there any idea of why the pancreas in particular develops these cystic lesions as we age?
There are some research models using animals, genetically engineered animals, and other models of pancreas injury, like low-grade pancreatitis models, that all suggest that this is a inflammatory response in the pancreas from probably chronic, what I tell patients, kind of chronic low-level inflammation that could come from diet, high triglyceride diet, alcohol use, stones in the gallbladder with small amounts of pancreatitis. And then what we believe is that this is a metaplastic change in the epithelium in the pancreas, just like Barrett's esophagus, polyps in the colon. Kind of those are similar analogies that I think probably all feed back to a common mechanism.
Now, you didn't mention smoking. Is that a risk factor?
Smoking for cystic lesions of the pancreas is not something that I think is well worked out. certainly a risk for it's been associated with pancreas cancer, but cystic lesions, I'm not so sure.
Well, let's talk about the different types of cysts. So, and I'm going to mention some, and why don't you give us a brief idea of what the general surgeon should know about each of these? So let's start with a mucinous cystic neoplasm.
The important thing, I think, when you have a patient who has a cyst who comes in to see you is just to start with the basics of a good history and physical like we were all taught to do. And the reason is that these cysts cluster, some of them cluster with age and gender. Mucinous cystic neoplasms is one that is overwhelmingly present in women, usually in the 50s to 60s or older age. It's unclear exactly why that is, but when a pathologist looks at these, if they're removed, they have what they call ovarian stroma in them that actually has estrogen receptors. And it's believed that this is a complex that may be not dissimilar from polycystic ovarian disease or other changes that you see in women of this age. So a mucinous cystic neoplasm has malignant potential, so it's considered a premalignant lesion or a malignant lesion, depending on the presence of cancer cells within the lining of the cyst. And so this is potentially driven by estrogen or other receptors, although no one's worked that out completely.
And it's opposite, or I'm not sure it's opposite, but the other one that comes up is serous cystic adenoma.
Right. So when I talk to patients about this, I kind of draw an algorithm that has serous lesions on one side and mucinous lesions on the other. And serous lesions are, in general, not considered premalignant. So a serous cystadenoma, or what they call a microcystic serous cystadenoma, those lesions have the fluid inside is not mucinous but serous. And the serous cystadenomas are often imageable on a CT scan, and a good radiologist will be able to see the small cyst within a larger cyst or the central scar that you would see, and they will indicate that they believe it's a serous cystadenoma. Also on ultrasound, you'll see the small cysts clustered together, and if they do aspirate it, the fluid will be non-viscous. And those things together, and often the CEA, the carcinoembryonic antigen, which is a mucinous antigen, will be low in those. And when you put that together, most of those serous cystadenomas are not going to be, they don't cause the malignant progression and metastatic disease that you might see in the mucinous lesions. And so often those could be monitored in a patient if small. The general teaching is if they're greater than 4 centimeters, then resection should be considered. But essentially, the resection is performed for a mass effect from the cyst.
Before I get to the one that always is most confusing, let's talk about a solid pseudopapillary neoplasm.
So there again, taking a basic history is very important. They're rarer tumors, but they're most commonly found in young patients, often in their teens or 20s, often female, often women. They can become very large. They have a very specific genetic changes associated with them. Pathologists can stain for beta-catenin, which is just a specific molecule that has to do with the biology of these, and they will be positive. And those patients are often cured by resection. They have a low rate of metastatic disease and often don't need any additional therapy other than surgery.
And usually that's another resection that many times is done for a mass effect. Is that not true?
Correct. These will be a mass that's seen often in the head, often compressing the portal vein, but can be in the tail. But yeah, it's a mass effect. But you would want to resect these. They have theoretic potential for metastatic disease. It's listed as about a 1% rate of metastasis. So resection is usually indicated.
Well, let's go to the one that usually is the headache for most general surgeons, including myself, trying to keep it all straight, and that is intraductal papillary mucinous neoplasms.
Right. So IPMNs fall into so they're in the mucinous category. So remember the serous and mucinous. So these mucinous cystic neoplasms and IPMNs are in the same family, but if you look at the genetics, they're different. IPMNs occur in older patients. Historically, it's 60, 70, and 80-year-olds. Usually men and women are the same in distribution. I usually further divide these into three categories based on anatomic findings. So there's the main duct in the pancreas, and then there's side branches that feed the main duct. And an IPMN developing in the side branches usually presents as a sphere not involving or not dilating the main pancreatic duct, and those are called side branch IPMNs. And then the main duct IPMNs obviously involve the duct and can be anywhere along its length, and often are involved have skip lesions that maybe are involved in one part, and then maybe the head, and maybe the neck. So the complete length of the duct is often involved and becomes dilated from the mucin that's secreted by these cells along the duct, giving that dilated effect. So mixed side branch and main duct involve both. So you would see that spherical shape, and then maybe the main duct is dilated right next to that. There are consensus statements that are designed to help direct management because it can certainly be confusing. The international consensus statement was last updated in 2012, I think, and it categorized side branch as lower in risk than main duct. So the first thing to think about is that a main duct IPMN is going to be more likely to harbor malignancy than a side branch. It's recommended that surgery for main duct dilation of 8 millimeters to a centimeter is likely recommended. Some say smaller size, even 5 to 9 millimeters. The point being that a main duct IPMN should be considered at risk for needing resection. How much you remove and what part you remove would depend on some decision making regarding where along that main duct you think a lesion is. A mural nodule is considered to be degeneration of those cells that are making mucin into a malignancy. And so that should drive resection and considered a high-risk lesion if a mural nodule is seen along the main duct. The side branch lesions risk is generally driven by size. So the radiologist will measure the size of the lesion. The general consensus is that greater than 3 centimeters or thickened cyst walls or a mural nodule are all considered high-risk features that should prompt additional investigation and may lead you toward surgery for that lesion.
Help me clarify something. So the IPMNs, everybody worries about missing a cancer. Is that not kind of the fear when IPMN surfaces as a potential diagnosis?
Right. Like we talked about, an IPMN change in the pancreas is usually driven by the chronic inflammation and is believed to be a premalignant condition not dissimilar from a colon polyp or Barrett esophagus.
You kind of mentioned size, and you kind of threw out the 3 centimeters, which is in most of the guidelines. As you mentioned, the 2012, the Fukuoka, or how do you pronounce that? Those guidelines. It used to be Sendai, and now it's
Fukuoka.
Yeah, and then there's the AGA guidelines that are also out there.
Right.
So my question is, if you have one that's 2.5 centimeters, are you watching those these days? Are you following them with repeat CT scans? How exactly do you recommend following that IPMA when the threat or the potential of malignant degeneration is there?
Right. If those findings of a 3 centimeter size or enhancing cystic walls or mural nodule is present, or dilated main duct, or atrophy of the tail of the pancreas, that would trigger to me an endoscopic ultrasound request with an FNA. if they see these. So that's your next echelon of investigation. So I would ask our colleagues to perform an endoscopic ultrasound. If they see a mural nodule, they'll usually biopsy it. They'll aspirate the cyst to confirm that there's mucin present and to look at the cytology to see if there are cells that are suspicious or positive for malignancy. And if you see those, then surgery should be considered. If you don't, then you go into those categories that you just mentioned where you use size to drive what you do next. Okay, so if a cyst is under 1 centimeter and has none of those findings, then I would probably image that person in 2 years.
2 years?
Yeah, if it's under a centimeter, yeah. And you can use CT or MRI. Usually, if I feel like we're going to be getting more CT scans in that patient, I try to switch to MRI to limit radiation exposure. If the cyst is 1 to 2 centimeters, then I probably would do the first one annually, so first one in a year, and then stretch it out to 2 years after that if the cyst size is stable. So what you're looking for is a change in size or any of those findings that we talked about that would trigger that endoscopic exam or other investigations. And then if it's in the 2 to 3 size and you want to keep a closer eye on it, usually we would do 6 months and then try to stretch it out if we can, if it's stable, but probably repeat a couple 6-month visits with imaging and see kind of what this does. If it's greater than 3 centimeters, then I think you need to, if you're not going to perform surgery, you would definitely want to image that in 6 months. But in a young patient where you know that there's a high likelihood that this would progress during their lifetime, you're probably headed toward the operating room.
That was going to be my next question related to your experience in following them. Do most of these change, or do most of them stay the same or go away?
Most of them will increase in size. The rate of increase is somewhere around 1 millimeter to 2 millimeters a year if you look at what's published. But what you're really looking for is to catch one of these that is changing more rapidly or has a developing cancer, and you could identify high-grade dysplasia or some trigger and prevent that cancer from forming in that cyst.
Anything we've missed talking about cysts that you think a general surgeon needs to know?
Always remember to query for history of abdominal pain or emergency room visit that would be pancreatitis. So there are patients who will be sent to you who actually were identified in the emergency room with abdominal pain and had a CT scan that actually have a pseudocyst that will most likely resolve if you re-image them in 6 weeks.
Good point. You always forget about that benign cyst that still happens.
That's right.
Let's take another topic, which is, it's interesting. If you look through our doctor books, it certainly has changed its name. I think it's pretty well established now that we have something called neuroendocrine tumors, or NETs. So let me just ask you, what are they?
So this is a family of neoplasms. So they are neoplastic that are derived from neuroendocrine cells, which completely line the GI tract and also are in the lung and even the thymus. And these are cells that act to coordinate neural and gut hormone signals throughout the body and are often involved in motility. The neoplasms that arise from these are all really part of a family called GI neuroendocrine tumors. So you'll see GI NETs, and there's a separation if you look at the genetics between the different anatomic locations. In other words, they're not all the same. And that's borne out by how the patients, the survival of patients who get these tumors in the different locations. So a pancreas neuroendocrine tumor is genetically very different from a small bowel neuroendocrine tumor, which we historically have called carcinoid tumors, but they're part of this larger family that are all neuroendocrine tumors.
Now, even in the small bowel or the carcinoid tumors, as you pointed out, we have something called foregut and hindgut carcinoids. Are there difference in those?
Yep, absolutely. They have different genetics. If you look at the chromosomes of those, they're not the same. And if you look at survival of patients, someone with a small bowel carcinoid that's localized is going to have a different survival from somebody with a rectal carcinoid. The small rectal carcinoids have a better prognosis than a small bowel carcinoid, which is better than pancreas, let's say.
And the other thing that we seem to be seeing more of, or at least I think in our practice we've seen more of recently, is the patient who comes in with a small bowel obstruction, doesn't have a scar in their belly, doesn't have a hernia, and lo and behold, somebody suggests that they have a carcinoid that is causing their small bowel obstruction. Is this something that I'm not making up? Is this something that happens with the carcinoids in the small bowel?
Absolutely. These tumors are unique in a couple ways. One is they're arising not from the mucosa, but in the kind of submucosal space. But more uniquely is the tumors make serotonin and other kind of kinins that are then taken up by platelets and other immune cells. So they trigger a significant immune reaction, which essentially creates scarring around the tumor that then drives the obstructing symptoms that they get. The other mechanism of spread of these is to the regional lymph nodes. So let's say we're talking ileal carcinoid, which is the most common. It's very common to have metastatic disease along the ileal chain, along the ileocholic artery and vein, up to all the way up to its insertion into the superior mesenteric artery and superior mesenteric vein. And these tumors can become very bulky and are often the first kind of discovery on a CT scan is a mass. There'll be a mass in the mesentery, and that mass will have a lot of scarring around it, not all of which is cancer. Biopsy, which is important to note, in that attempt to biopsy these often leads to non-diagnostic samples. There'll be cancer cells, but most of the mass itself is this reaction to these chemicals.
And the CT findings on these is really a sclerotic mesenteric changes in the area of the obstruction. Is that true as well?
Correct. Often what the radiologist is seeing is these sclerotic lymph nodes that are often matted together. They'll also obstruct the veins that drain a portion of the small bowel, and that can drive patient symptoms. Often postprandial pain is what patients describe, and essentially this is venous congestion of a portion of the small bowel related to this mesenteric mass that is knocking off these veins that drain it.
And usual management then is if you get there early enough, resection?
Correct. The principles of this are to try to achieve a resection that takes the primary tumor and the regional nodes along that anatomic lymph node basin if you can. I think it's important to understand that if you see those lymph nodes and they're above and they're in the mesentery, taking the primary tumor out could be helpful for acute small bowel obstruction, but that bowel that's left below where all those lymph nodes are enlarged could be at risk for not healing well, could also cause secondary obstruction later. So the goal would be, if possible and safe, to remove the primary tumor and those regional nodes. There's data to suggest that survival of these patients is most driven by obstructions and portal vein venous obstruction related to that central mass. So removing that can prolong survival in these patients.
Is there any medical treatment that is used either adjunctively or neoadjuvant therapy?
Not usually in the scenario of that we're describing. These tumors have somatostatin receptors on their surface, so the use of analogs such as lanreotide or octreotide to block those receptors can be used in cases where they have disease that can't be removed, a big tumor that you can't take out, or a patient who is not a suitable surgical candidate and doesn't have symptoms driving you to do surgery. These can be given as a subcutaneous injection or an intramuscular injection and can have a good track record of controlling tumor growth for an extended period of time.
Well, let's change the topic a little bit and let's talk about gastric carcinoids, and there seems to be another separate classification system for these. Is that true?
Yes. So these are usually classified into three types. Unlike the tumors we were just discussing, they're driven by a different gut hormone kind of cycle, if you will. Gastrin is usually driving these gastric carcinoids to growth. The concept is that chronic hypergastrinemia, which could be caused by either atrophic gastritis or a low chloride state in the stomach, will drive gastrin production by G cells that will then cause what's called ECL proliferation, or these enterochromaffin-like cells in the stomach to grow, and then those can become the carcinoids that are seen on endoscopy in the intraluminal side of the stomach. So the classification is designed to help understand which is driving the growth of these carcinoid tumors. So a type 1 is associated with chronic atrophic gastritis. It's an autoimmune disease where the chloride production in the stomach is down from the parietal cells that normally make it. That is most common. So that's about 70 to 80% of gastric carcinoids are from that. I think we have to remember that pharmacologic suppression of acid secretion, so proton pump inhibitors that are widely used, can drive achlorhydria and could drive this process, although it's a little controversial if they are actually causing these, but I think you have to keep that in mind. In that scenario, there's multiple tumors, usually in the antrum and the duodenal bulb. These are usually small in size, under a centimeter. They're indolent. They don't metastasize often, but can. So in other words, it's possible, but it's not routinely seen. I think the type 2 is the classic Zollinger-Ellison syndrome. So that is an endocrinopathy where a gastrinoma is making pathologic levels of gastrin. Usually, if gastrin levels are measured in the blood, it can be in the greater than 400 range, or greater than 1,000 is diagnostic. And that then drives the proliferation of these ECL cells. Usually multiple tumors are present, usually in the antrum and the bulb. Again, smaller in size, slow in growth. Metastasis rates are usually in the 7 to 12% range. And the patients these aren't aggressive tumors in both of these, 1s and 2s, that would rapidly metastasize to the liver. When we're speaking of serum gastrin levels, I think it's really important to understand, if you're drawing this test, whether a patient is taking proton pump inhibitors or not. Just the use of proton pump inhibitors can give gastrin levels in the blood that are in the 200 range, which can make it difficult to interpret if a patient actually has a gastrinoma or not. So it's recommended that the patients be off proton pump inhibitors for, usually we tell them a week if they can stand it, before we draw their blood to check.
And what about that type 3? That's the one that always fascinates me.
So type 3s are, these are sporadic, probably genetically driven versus hormonally driven tumors. So these are more traditional neuroendocrine malignancies, more like a carcinoid or a pancreas neuroendocrine tumor. So these are usually solitary. They're usually larger. They're usually greater than a centimeter. The gastrin level will be normal. The mucosa around them will be normal. They can be imaged on these special nuclear studies that image according to the presence of this somatostatin receptor. So these are the old octreotide scan, or the more recent, what's called a gallium-68 dotatate scan. these will show up as positive. The important thing about these is that they are aggressive. They metastasize to the lymph nodes, and that's found in about 55% of cases on diagnosis. And they metastasize to the liver in another quarter, about 25% of cases. So 5-year survival is under 35, 40%. So these need an operation that is not an endoscopic removal of the mass. They need more of a formal operation like a gastric cancer. So removal of the stomach where the tumor is, regional lymph nodes, etc.
I have 2 more questions in this area. So the carcinoid syndrome, is it more common with one type of neuroendocrine tumor or carcinoid? And have we come farther in our understanding of what to do with somebody who really has carcinoid syndrome?
I can't say we've broken the code, but we know a little bit more about it. So this is a systemic consequence of serotonin and these other kinins that these tumors make. So this is we will call a paraneoplastic syndrome. It's related to the tumor and it's a secondary effects. So the carcinoids release these chemicals which are normally taken up by when the tumors are on the portal venous side of the liver. These chemicals are very efficiently filtered by the liver so that the systemic circulation never sees these chemicals. The reason that's important is that it will be very rare for a patient to have carcinoid syndrome and have a small tumor within the ileum of the small bowel. So patients often get online and read about carcinoid syndrome and often believe that they're having those symptoms. And it's usually not if they have a localized tumor without liver metastasis. The one exception would be a larger tumor that is draining potentially into the retroperitoneum, where those veins would go straight into the systemic circulation. But it's unusual to see carcinoid syndrome without liver metastasis. The clinical findings, of course, are the skin flushing, diarrhea, bronchoconstriction or asthma, and the important one to screen for is right-sided heart disease. So if a patient does have carcinoid syndrome, which they have about a 40% chance of having carcinoid heart disease. So this is related to chemical exposure on the right side of the heart. The tricuspid valve is most commonly associated with that and can cause significant morbidity if unrecognized. So if a patient is going to the operating room for, let's say, resection of a liver metastasis that's related to a neuroendocrine tumor, all those patients are screened with a cardiac echo before they go to the operating room to look for unsuspected right-sided heart disease.
That's a great review of the carcinoids that we often may face. Let's go to your primary activity, which you indicated at the beginning of this interview, and let's talk about that adenocarcinoma of the pancreas. And I guess my first thing is a lot of talk in the literature about the epidemiology, and it seems to indicate at least that we have an increasing prevalence and incidence of adenocarcinoma. Is that a fair statement?
I think it is. Unfortunately, I think it's believed to be driven by increasing age of the population. So we know that age is a risk factor for pancreas cancer. And as the population ages, the incidence is going to rise. Unfortunately, therapeutically, we haven't made advances, so the mortality is still in the 95 plus, 90 to 95% range, 5 years. So what that means is that the projected number of cancer deaths for pancreas cancer, if nothing changes, would increase over the next 10 years to where pancreas cancer could be the number 2 cause of death in the United States. And I think the other contributor is the obesity-driven malignancy, in that a sedentary lifestyle and metabolic changes related to that are believed to be driving the increase in pancreas cancer that's specific and different from what was driving the disease maybe 15, 20 years ago.
So we're still dealing with a mortality rate of 90 to 95% at 5 years?
Yes.
Now, there's also been a lot of movement or suggestion that we've got genetics at play as well. Is that something that is actively being investigated, or are there certain genes that seem to correlate with pancreatic cancer?
One of the bright spots in pancreas cancer is that we're learning about some of the risk factors that are specific and actually offer strategies for treatment. One is the inherited risks, which include some known genetic players in other cancers. BRCA or the BRCA genes are known for a long time to be associated with breast cancer, but one of those, BRCA2, is particularly known to be associated with pancreas cancer. This is a DNA repair gene, a specific one, and if identified, those patients are at increased risk for pancreas cancer in their lifetime, but they are also increasingly responsive to certain chemotherapeutic agents, namely the taxanes that would cause DNA damage. So as we learn more about these inherited risks, it's unfortunate for the individuals who have those who would have to undergo screening, but it also offers, if they do develop cancer, it offers some therapeutic strategies for us.
Now, let me ask you to help us clarify, because there's a number of questions in CSAP 17 that relate to how we classify the pancreatic cancer. And we seem to be using the terms localized, advanced, borderline resectable, and non-resectable. There's a bunch of definitions. Most of them agree, but some are a little different than any. Can you give us a description of what each of those mean in some way that we can maybe remember it easier?
Right. I couldn't agree with you more that that's a lexicon nightmare. And part of it is that we use terms that are not precise, like abutment or encasement in a pathology report, which makes it hard to interpret what that actually means. So I think the first thing is why do we have these categories? What do the categories mean? And I use three categories if we're talking about localized pancreas cancer. So this means they get a CT scan, they don't have metastatic disease, the tumor's sitting there in the pancreas. So the three categories I use are potentially resectable, meaning what I tell patients is that means that I believe as the surgeon we could go to the operating room tomorrow and we could take this tumor out and we would have a high chance of having a margin negative or no cancer cells at the margin resection. Locally advanced is the other end of that spectrum, which is I do not think that we could take this tumor out without leaving cancer behind. So the in-betweens are the borderline resectables, which means my confidence level is in between those two other categories. And so to help develop that, what that means and to interpret from imaging, those categories you referenced are developed to give us handholds. The general rule is that if the tumor is involving over 180 degrees of the vein or encasing the vein, that patient would be in a borderline resectable category. And that's the vein. The artery, if there is more than abutment of the artery, in other words, more than 90 degrees of that artery is involved, that patient would be in the locally advanced category. So the concept is if the tumor is free from the vein and the artery, they're in the potentially resectable category. So when we say artery, we mean superior mesenteric artery, hepatic artery, and when we say vein, we mean portal and superior mesenteric vein. So if there's a dark plane you can see on the CT scan between those structures and where you believe the tumor to be, and the vein is not deformed or compressed, then that's a potentially resectable tumor. The locally advanced category is usually driven by the artery. If the superior mesenteric artery or the hepatic artery have over 90 degrees of involvement, where you don't think you could safely get that tumor away from the artery without leaving cancer cells behind, those patients are in the locally advanced category. With regard to the vein for the locally advanced, if that tumor encased the vein in such a way or obstructed the vein in such a way where you could not safely take it out or do any kind of reconstruction of the vein afterwards, those would be a locally advanced category. And then the borderline would be everything in between those. And so what you can see listening to me is that it very much involves the surgeon's understanding of what their ability to remove the tumor and achieve a margin negative resection or an R0 resection.
So you mentioned removing the artery or replacing the artery. So that could still be a locally advanced patient, or would that, if you had to go to that extent to transect the artery, put a vein graft in, is that somebody that's more borderline resectable or locally advanced? That's one of my confusions.
The vein resection and replacement would be in the borderline category. An artery resection, to me, artery involvement would be a locally advanced case. And the reason those are different is that these tumors grow along nerves. And if they're encasing an artery, often there are tumor cells growing along that artery in those nerves and the adventitia along the SMA. That's a biologically different tumor than another one. We believe that resecting that artery, and there are different, this is not universal, but many believe that resecting that artery is going to be maybe not associated with as good an outcome as one would want from a cancer standpoint.
Now, what about neoadjuvant therapy on that borderline resectable? Isn't that what you guys are doing now?
So, right, there's general consensus and actual publications. One that's most recently come from Europe that suggests that preoperative therapy, multiple single institution studies suggest that preoperative therapy offers a superior survival advantage for patients who undergo pre-op therapy and then undergo surgery. An important caveat to interpreting this is that the patients who receive preoperative therapy, not all of them receive surgery. So there's a dropout rate of patients who receive pre-op therapy and don't receive surgery. That's about 40%. So those patients progress, either they develop liver metastasis or other metastatic events while on chemotherapy or prior to surgery, and they don't receive surgery. So interpreting the survival results, it's important to understand that the patients are selected to undergo surgery by the preoperative chemotherapy that's been given, and that's one of the rationales for giving it. The other rationale is that if you look at postoperative chemotherapy, if surgery is performed first, if you look at any of the major trials where it's been performed, the rate of receiving post-op chemotherapy hovers at around 50%. So in other words, if surgery is performed up front, the patient has about a 50% chance of not receiving all adjuvant therapy, chemotherapy afterwards, which we know is associated with an improved survival outcome. To me, those are the two main rationales for giving preoperative therapy, and I think that's become, of the three categories for the borderline, that's become the, I won't say standard, but it's become accepted practice.
Now, this year at the American Surgical, there was a paper that was presented that raised a lot of discussion, and that was the type of chemotherapy, and that was the gemcitabine versus FOLFIRINOX. Do you think that's going to change things?
So the way these studies have developed is the agents that are used in pancreas cancer, like FOLFIRINOX or gemcitabine, are first used in the metastatic setting. And then if they show promise, then they're used in the adjuvant setting after surgery. And so as these agents have developed, it's been shown that and published that FOLFIRINOX has an improved survival profile over gemcitabine. So the next logical approach is to use FOLFIRINOX in the preoperative setting because we would anticipate the response rates are improved. The downside of a combination of agents like FOLFIRINOX is that the toxicity rates are higher. We grade toxicities with chemotherapy as grades 1 through 4. 75% of patients who receive FOLFIRINOX roughly have a grade 3 or 4 toxicity. That can be significant if the goal is to get someone to the operating room, and if toxicities from chemotherapy prevent someone from receiving the benefits of a surgical resection, then we've kind of moved away from our goal, which is to get them chemo and surgery. So I think the jury's still out. There's no doubt that FOLFIRINOX has a good response profile when compared to gemcitabine, but I'm not sure we're ready to say all patients who get pre-op therapy should receive FOLFIRINOX in lieu of other agents.
So in other words, you trade off a better response rate with a higher failure rate preoperatively in the patients who actually get the surgery.
Potentially, right? So if the worry is the dropout rate and you make that higher, then we might be moving the direction we don't want to go. Obviously,
pain control is a big issue, or I guess we should say pain treatment is now a big issue, certainly in the United States and worldwide with the what a lot of people would call the opioid epidemic. So many of these people have lots of pain. Are celiac blocks still something that is useful in treating somebody with non-resectable disease who has significant pain from their cancer?
It definitely has a place, but I think it's very important to work through your algorithm before going straight to the block. I think the mistake I see is that a move toward the procedural answer when there's some other interventions that have less risk. Those blocks have not insignificant risk of hypotension for the patients and other negative consequences, and they're not really reversible. So what I mean by that is that most of these patients have pancreas enzyme insufficiency. So with these tumors, they often don't make enough pancreas enzymes to properly digest food. And what happens is they develop pain after they eat because they're enzyme insufficient. That requires the taking of replacement enzymes orally before you eat. And often those pains, which are essentially gas pains that they're having and poor motility, those will often reverse and their nutrition will improve just with that simple intervention. And so I would just ask the listeners to think about those types of interventions first. Also use the stepwise intervention that's published with regard to pain control using nonsteroidals and opioids together or alternating is very effective. Often I see patients who have been given a prescription for opioids and they're using it incorrectly. So pain control for cancer pain, when those medications are used, they should be taken regularly. So what I often do is I ask them what dose they're taking, and they'll tell me, and I say, well, how often do you take it? And they'll say, well, I just take it whenever I have pain. So what happens there is they're never getting a steady state of level. And a simple maneuver is I tell them just take that every 8 hours or every 6 hours, depending on the dose and the patient. And then let's measure what your breakthrough pain is, and then we'll add on top of that. And often those two maneuvers, they handle 80% of the patients I see who have cancer-related pain, and they never need a block. And so these kinds of interventions, I think, are really what I would encourage people to do rather than just go straight to the block. The blocks can be very effective for patients who have specific nerve-related pain from tumor growth into the celiac plexus or these other nerves along the arteries in the retroperitoneum of the upper abdomen. They usually have a pretty specific pain profile, which is mid-scapular or lower scapular back pain directly in the middle. They feel like it's moving from front to back or back to front. And blocks can be very effective for those if properly selected.
Let's leave pancreatic cancer behind, and let's talk about chronic pancreatitis. I know you have a little bit of a vested interest here as well, and I just want to cut to the chase. And there are really 3 surgical procedures that you read about when you get to surgical treatment of chronic pancreatitis. That's Pusteaux, Beger, and Fry. And I guess I'd ask you a simple question, very simple. So which one's better?
You know, in surgery, we don't have a lot of randomized data for different procedures, but we actually have some data for these. It's because some clinical investigators with very focused practice have worked on this problem. So if you start out as a randomized study of patients who received lateral drainage versus a Fry procedure. So the Fry procedure involves opening of the main pancreatic duct. So the driver for these operations is most commonly pain, and that pain is most commonly associated with the presence of an obstruction of the main duct from a stone or a stricture, usually at the level of the genu, where the duct enters the head and then bends posteriorly before going toward the ampulla. And so the strategy here is to achieve decompression of that main ductal system as much as possible. The Pusteaux offers a safe approach to that dilated main duct, but it doesn't get you relief from that portion of the main duct which is in the head of the pancreas. So both the Fry and the Beger are designed to decompress that portion of the main duct by either removing the head of the pancreas in the Beger or creating removing a core of tissue that opens up that space around the main duct in the case of the Fry. So there's randomized studies comparing resective versus Fry, which showed that these hybrid procedures like the Fry have better pain relief and better quality of life. And so when they look at patients when they give them quality of life scores after these procedures, they show improvement with these hybrid procedures over a resection. Now, when Beger and Fry are compared head to head, there's not really significant differences found. In other words, so a Whipple is not a great operation for this. A Pusteaux is not a great operation for this, but these hybrid procedures that include the Beger, which is kind of a resective and then drainage, or the Fry, which is a drainage procedure with that coring out of the central head, both have, in the hands of experts, both have equivalent mortality, equivalent endocrine and exocrine insufficiency afterwards.
Well, I've got to ask the question because I spent some time at Minnesota, the University of, and what about pancreatic islet transplantation for chronic pancreatitis?
Well, it sure does make a lot of sense to just remove the pancreas and then give these islets back. I'm not a transplanter myself, but usually these are offered to patients who have diffuse chronic pancreatitis that's not suitable for these drainage procedures, or they have refractory pain and are otherwise acceptable candidates. There's about 5 studies that are out there that include about 300 patients. 2 of those studies show a decrease in postoperative opiate use. Usually, as with any of these chronic pancreatitis studies, relief of pain is a heavy overlay of narcotic use and abuse or long-standing pain, so it's difficult to interpret. Insulin independence is really the metric that people have looked at. In other words, can you take the gland out and give them auto islets and have them not need insulin? So about 65% of the patients do not need insulin at year 5, but there's a progressive decrease in those that are free of needing insulin. In other words, more of them need insulin over time to where it's only about 10% at 8 years. So that calls into question the cost effectiveness of this, in that it's a heavy lab element. Harvesting the islets is a highly specialized activity, requires a very high expense, so unclear if it's worth the effort.
I would say that's a fair assessment of the pancreatic islet transplantation literature. Let's move on a little bit. And it's interesting. We have a question on sinistral portal hypertension in CSAP-17. It was interesting. We had a lot of discussion about it when it was reviewed by the committee. So first, what are we talking about? That was one of the questions by one of the members of the committee.
So this is an anatomy question in that the portal system beneath the pancreas, the portal vein, splenic vein, and superior mesenteric vein all come together in a T-shaped configuration where the splenic vein is draining the spleen off to the left. If a patient gets chronic pancreatitis or an acute pancreatitis event or a cancer in the tail of the pancreas or the body of the pancreas, occlusion of the splenic vein can occur. If that happens, the spleen still has inflow from the splenic artery, creating a physiologic event of increased pressure in the left side of the portal system, meaning that the liver's fine, the bowel is fine, but the spleen is enlarged, and there's pressure in that system that then manifests as varices draining into the stomach or across the stomach to get back to the liver, so gastric varices. This can lead to chronic anemia from low-grade bleeding or frank hemorrhage, which can be significant. This can be difficult to diagnose in that those patients typically will have an upper GI bleed, and then they'll come into the emergency room, and then they'll be relatively hypotensive, and they'll undergo endoscopy, and there'll be blood in the stomach and stigmata of bleeding, but you can't identify the actual source. So it can be very difficult to diagnose, very difficult to treat endoscopically. So those patients can kind of present a clinical dilemma of what to do. On imaging, they'll have a spleen that's enlarged. They'll have a low platelet count on laboratory values because they're sequestering in the spleen. And the solution that's been traditionally offered and published as a viable solution is to take the spleen out, essentially removing that capillary bed that's being supplied by the artery. An alternative solution would be that's offered up and useful in some patients would be embolization of the splenic artery. The problem with that is that you create a significant amount of pain and ischemia to the spleen. Often those patients need to be admitted to the hospital. They can develop pleural effusion, so it's not without its own risks, and sometimes it's less than effective. The third option that's been published not so much in the U.S. literature, but overseas, has been interventional approaches to sclerose those gastric varices. Essentially, it's like the old devascularization procedure of the upper stomach in an attempt to reduce the bleeding risk. I don't know of many centers in the U.S. that have a lot of experience with that.
All I can think of when I read those articles is after looking at those gastric varix or varices through the endoscope and thinking that I'm going to sclerose those and not get more bleeding, it scares the daylights out of me. So I won't be trying that. I'll guarantee you that. So splenectomy is much more appealing to me. Well, I got one more topic I'd like to pick your brain on, and that is it's been interesting watching the questions on GISTs peak in, I think they peaked in CSAP-16, and they're now falling off again. They started in 15. So let's just talk about all of these GISTs have malignant potential, but the diagnosis of malignancy is not always easy. So what do you use or teach is what is necessary to call a malignant GIST?
As you said, these patients often present in different ways, and often the smaller GI stromal tumors will present as the traditional leiomyoma of the stomach, or where they're a submucosal mass. They're not necessarily, maybe the patient has had some anemia that triggered the endoscopy. but the mucosa overlying it is usually normal. It may have a small ulceration in it. And fortunately, with the improvements in endoscopy and endoscopic ultrasound, most gastroenterologists that are assisting or working with you could put a needle into that mass and get some cells out. And a core biopsy would be even better because you could see some architecture. But even if it's just cells, the rest is a cytopathologist who, and kind of an awareness of the possible diagnosis of a GI stromal tumor, should trigger some special stains looking for this c-KIT or CD117 molecule. And that's essentially diagnostic that this is a GI stromal tumor. But it doesn't tell you the kind of malignant potential. That can, however, be determined by mitotic count. So looking at the rate of division of those cells. So let's say you were able to get the core biopsy and they could give you those kinds of numbers. So now you have a rubric that you can actually use to look at risk. So there's really three things that drive outcome in GI stromal tumors. One is the anatomic site of origin. So whether it's gastric or whether it's small bowel makes a difference. Small bowel GI stromal tumors are not going to have as favorable an outcome as gastric. Second is the size. So we break them down by usually less than 2 centimeters, 2 to 5, 5 to 10 or greater. And those categories actually help you classify, put these into buckets, if you will, of risk. And then the third is this mitotic count. And so if you had that 4 centimeter gist, let's say, and it has a low mitotic count, and it has, or let's say 2 centimeter gist, and it has a low mitotic count, and it's not a patient who is a very good candidate for surgery, and it's in the stomach, you could make an argument to monitor that patient and not necessarily perform a gastric resection if it's, let's say, located up by the GE junction in a place where reconstruction can be difficult. So I think the important thing here is to, one, think about that it could be a GI stromal tumor and obtain that diagnostic staining, and then next use those three categories to risk stratify the patients to help you make decisions as to how much or the necessity of surgical resection for that patient, or if any other therapy would be indicated.
And the mitotic count that we use to separate benign from malignant is what?
It's not dichotomous. It's not one is benign, one is malignant. It's a spectrum, right? So it'd be less than 5.
I think right now it's greater than 5 is when the diagnosis comes, and obviously the more mitosis that occurs or the more mitotic figures you see, the greater the risk of the malignant potential. But 5, I believe, is the cut point.
Okay.
So that leads me to my next question, Jason, and that is, so you have that 3 centimeter, you mentioned to observe them, but how about that 3 centimeter with a low mitotic count? Do you just enucleate that from the stomach? Do you have to do any kind of resection?
From a technical resection standpoint, a resection with negative margins is acceptable. So you could get there through many different means, either laparoscopic, robotic, intramucosal. You're running the risk of that positive margin at the edge of your resection. But I know that using a stapling approach and an intragastric approach is performed. In other words, going into the stomach and then actually stapling off the mass from the mucosal side is being performed. So there's many different options. It really doesn't, from a cancer standpoint, it doesn't matter how you get there as long as you achieve a margin negative resection, meaning, and it is important to have your pathologist involved when you take this specimen so that they can gross it with you, ink the margins that are potentially at risk for permanent evaluation. You don't need to do frozen sections, though.
Well, it's been nice talking to you this morning, sitting with you and going over a bunch of these things. I appreciate your willingness to do this with me today. And I guess I'd just ask you, you've been with CSAP for a while. Is it still pertinent to general surgeons as a learning opportunity? Let's put it that way.
I think so. I'm a believer, and there are many different ways to spend your time and staying abreast of kind of the current field. The statistic I always remember is that medical knowledge is estimated to be doubling every quarter now, so every few months. And so staying pertinent is more important now than ever. The use of questions that have been written by your peers and reviewed by your peers is really a super efficient way to make sure that you're kind of in the know, so that you're hearing questions that are on other people's minds. Therefore, most likely they're questions that are going to be pertinent to your practice. So I think for all those reasons, I think it's an excellent tool.
Well, thank you for those comments. Thank you for your input to CSAP Audio Companion, and I certainly hope you have a wonderful rest of the afternoon.
Thank you, John.
Thank you, Jason.
That's it for this category of the CSAP 17 Audio Companion.